Imagine this. You are extremely nervous and can barely focus. The doctor comes in and tells you the difficult news about your diagnosis. You hear it like wah, 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 but thankfully your sister is sitting next to you and taking notes. You walk out the door and a patient navigator is waiting for you with a cup of herbal tea and leads you to a quiet area with comfortable seating for all. She has all your follow-up appointments in a little book that has all kinds of information, websites, calendars of events for supportive care programs, and the phone numbers. She goes over all the information and asks if you have any questions. She introduces you to Patricia, the social worker, and Carl, the psychosocial counselor. This is the current reality for patients in Montreal at the Jewish General Hospital and has been for the past 30 years. As opposed to the reality here in Kamloops from a patient I'll call Anne. I saw many physicians and specialists during my treatment, but none of them seemed to be connected to each other. At every appointment, I had to fill out another long form with all the information they needed time and time again. As the patient undergoing chemo, radiation, hormone therapy, and several reconstructive surgeries and suffering the many side effects, I was the one expected to be the link and record keeper. It was exhausting. In Kamloops, we have a very busy BC Cancer Centre providing chemotherapy on the 8th floor of the main building at Royal Inland Hospital. We currently have 4 oncologists and 3 GP oncologists. We need more, who are dedicated to their patients and to improving cancer care in Kamloops for the local community and people from all over our regional hospital district. Connie from Vavenby was receiving her 3rd chemo treatment for breast cancer, and I met her yesterday up on the 8th floor. She traveled 2 hours to Kamloops and will travel another 2 hours back home. And thankfully, she has a husband who's able to drive her. I also met Ashley up on the 8th floor, the new social worker, 3 days into her new position, because there's a lot of movement around in interior health. And I spoke with all the nurses and admin support. These are the healthcare professionals you would meet if you were receiving cancer treatment at the Royal Inland Hospital. But what you wouldn't see is a robust supportive care program at this BC Cancer Clinic on the 8th floor of Royal Inland Hospital. It is lacking. But thankfully, now we have the Kamloops Supportive Care Society, and they are successfully advocating for more supportive care, and we at the Royal Inland Hospital Foundation are working with them. The Kamloops Cancer Supportive Care Society was founded based on overwhelming evidence that supportive cancer care services can improve patient outcomes and their quality of life and decrease the burden on the healthcare system. But you probably all know this. It was formed by volunteer, like-minded individuals with lived cancer experience, and it was formed to facilitate easier access to cancer supportive care for Kamloops and all patients, and to research the gaps in our system. They have done their research, and on their website, you can see the results of a patient survey regarding supportive care. And you'll hear things like patients said they were not able to access supportive services quickly, like counseling or support groups. And those who were successful often said they found it through word of mouth or by accident. One participant reported getting all her support and information from the Spirit Warriors Breast Cancer Survivor Dragon Boat team. Go Spirit Warriors, and they're represented here. Patients reported a variety of lasting physical side effects from their cancer and treatment, yet most patients reported not being referred to or informed of physiotherapy, massage, and counseling services. And almost all patients reported that their doctors were not equipped or overworked or nor had the time to refer or connect them with support services, and many stated that they themselves took the information they gathered back to their doctor to give to other patients. I urge you to read all the survey results. I don't think you'll find any surprises. But the Cancer Supportive Care Society, they've got projects underway, and we at the Royal Inland Hospital Foundation would like to support them. They want to develop, implement, and maintain a sustainable Kamloops integrated community network for cancer supportive care. They want to develop regular support group systems for all cancers, like any day peer support. And they want to develop a legal support network and financial guidance network to help patients access the resources they need. And then because I knew someone who knew someone, and that's how it seems to work. We now have Inspire Health virtually seeing patients in our region. You know, many people I know who attended Inspire Health programming in Kelowna after they finished their radiation treatment, they thought it was part of the BC Cancer Agency regular program. Like, after your radiation, please go this way, and you can go into a forum where they're going to teach you about dieting and what to eat. And they just thought it was part of BC Cancer. I couldn't understand why we didn't have that service here in Kamloops, and neither did Inspire Health. Inspire Health now provides medical, emotional, counseling, meditation, mindfulness, and physical, nutrition and exercise therapy, services online to all of the people in Kamloops and surrounding areas. And we do have intermittent in-person programs. We are helping get them more government funding to open a physical office in Kamloops. But in the meantime, the RIH Foundation has brought the LIVE program here to Kamloops twice already, and are hosting a third session this coming April. This 2-day program is absolutely free, thanks to 2 donors in Kamloops, and it's for up to 30 people living with cancer. We plan to continue offering a minimum of 2 programs a year. A strong supportive care program and the development of a truly integrated network for supportive care is needed here in Kamloops. This World CAFÉ is a great place to seek partners who would like to collaborate with us. And as you might be aware, on February 8th, we received the good news that we are finally going to get the long-awaited Radiation Therapy Cancer Center to be functional in 2028. The need for more supportive care and an integrative network where we all work together is needed now more than ever. I need to add supportive care to the fundraising campaign if in fact there is a gap and we need to fundraise for more things. Please contact me at the RIH Foundation or Leslie Brochu or Anne McCarthy at Kamloops Supportive Care Society. They're here today. Our contact information will be available after the summit. And this is a great forum for all of us to come together to establish and maintain the supportive care program we need and deserve. And as Harold P. Freeman said, no person with cancer should have to spend more time fighting their way through the cancer care system than fighting their disease. Thank you all. Have a great summit.
Thank you, Heidi, for welcoming us to the World CAFÉ Summit. The essence of patient-centered care lies in acknowledging that each individual's experience is as unique as a fingerprint. Now I would like to invite Colleen Foran, a volunteer, a BC cancer patient from the Family Experience Program, who's an ambassador of change, to come up and champion inclusivity, empathy, and collaboration in every facet of cancer care.
First of all, I would like to really thank all of you for the work that you are doing into living well with cancer. Excuse me. The biggest single problem in communication is the illusion that it has taken place. George Bernard Shaw reportedly said that, and today I'm here to talk to you about the importance of communication, of being heard. My name is Colleen. I'm an avid cyclist, downhill skier, pickleball player, longtime practitioner of yoga, and I was diagnosed with metastatic cancer just over 4.5 years ago now. For most of my career, I was immersed in studying and working with others on how we communicate. My story of cancer started with a diagnosis of stage 2 breast cancer in 2010. I was in the process of moving from Alberta to Vancouver, and my cancer was found completely by accident. I had requested that all my tests be updated before moving to Vancouver, but I never thought that anything would come of it. Although the initial tests were done in Alberta, I had to pick things up in Vancouver. My husband was already there and settling into a new job, and so I didn't want to worry him before I knew more. I felt really lost in the huge city, very new to me, no contacts, and no way into the healthcare system. I had to jump through many hoops to get further tests. Then the first time I met my wonderful new doctor, she had the very unwelcome task of telling me that I had cancer. She was so gentle and careful with how she communicated about my cancer that when I left her office, I felt like I could still function. I made an appointment to come back with my husband, but then I had to tell him. Telling my husband that I had cancer was the hardest thing to do because he had lost his mother to cancer 30 years previously. So that was 13 years ago, and I've lived with cancer since that time. My first meeting with my oncologist really helped. She was very direct and clear in her communication. She said, "It wasn't anything you did, it wasn't anything you didn't do. You just got cancer, and let's get on with treating it." I've replayed that over and over in my mind these many years. It was almost as if she heard without me saying that I had an incredible guilt for getting cancer. I went through surgery, chemo, radiation, hormone therapy, and I came through all of that really well. I was so grateful for the amazing treatment that I received from everyone at the cancer agency that I felt a strong desire to give back. This started my volunteer work with the Canadian Cancer Society Peer Support Program and the BC Cancer Agency's Patient and Family Experience Program. Through the Canadian Cancer Society Peer Program, I supported a couple of dozen women through their diagnoses and treatment for breast cancer. I heard so many stories, bore witness to their experience. It was a humbling experience. After about 7 or 8 years post-treatment, I was telling myself that I was done with cancer. But in reality, there was always that little voice in the back of my head that wondered. And it seemed that cancer wasn't done with me. In June of 2019, on my husband's and my 30th wedding anniversary, I went to my GP and told him that I was now having trouble eating and walking. We had been struggling to figure out what was going on with me for several months, and he said we'd better go up to the hospital to have a closer look. I spent most of the day on a gurney in the hallway. But then late in the afternoon, the GP came to me and said, "Is your husband in town? Can he come up to the hospital?" That's never a good sign. So when my husband arrived, my GP told us that the cancer had returned. And to be honest, I didn't react much to that because I didn't know what that meant. 1 week later, my husband and I were in Vancouver seeing my oncologist, who told us that not only was the cancer back, but it had metastasized to my liver. I wondered then, what does metastasize really mean? Oh, the cancer is incurable. It can be treated through palliative care. I think I stopped hearing much beyond those words, incurable and palliative. To me, palliative meant you're going to die, and soon. It was as if a cloud or a fog enveloped me, and I couldn't see or hear anything clearly, and I couldn't really comprehend anything. I had so many questions that I couldn't articulate at that moment. I wish I was in Montreal at that time, actually, now that I hear about that. My life had changed irrevocably, although I didn't realize it then. I didn't know where to turn to find out what it really meant to need palliative care, and I didn't know who could help me with this overwhelming fear that I didn't have long to live. Over the first year, I gradually came to understand what palliative meant. But the metastatic cancer diagnosis is a pivotal life experience. Nothing is the same after it. Any little twinge sends my mind instantly to the thought that the cancer's spreading. Intellectually, I know that there are many other reasons for me to feel a twinge, a sniffle, an ache, but my default thinking takes me directly to cancer. Should I buy something new for myself? Will I be around to use it? Should I plan a trip? It's very disorienting in that I often feel well, even healthy. The next thought that comes into my mind, though, is that I'm not healthy. I'm seriously not healthy. Relationships, communication, being heard by family and friends, all of that is fraught. At first, friends and acquaintances are sympathetic, really there to help. But for those who aren't that close, the sympathy starts to wane, and there's an unreal expectation that we'll get well, that the cancer, it's somehow that I'll get over the cancer. Just what part of incurable they don't understand, I don't really know, but family can also be really challenging. They don't want to hear that you're not going to be cured. We're not going to get well. Some of them just disappear. Some of them stay in that happy place of, you're strong, you'll beat this. And precious few, like my husband, have the emotional strength to stay by our sides. Mary O'Reilly writes in Radical Presence, Teaching as a Contemplative Practice, attention, deep listening. People are dying in spirit for lack of it. In academic culture, most listening is critical listening. We tend to pay attention only long enough to develop a counter-argument. We critique the student's or colleague's idea. We mentally grade and pigeonhole each other. In society at large, people often listen with an agenda to sell, to petition, to seduce. Seldom is there a deep, open-hearted, unjudging reception of the other. And so we all talk louder and more stridently and with terrible desperation. By contrast, if someone truly listens to me, my spirit begins to expand. This is the reason that metastatic support groups are so incredibly important. We greet new members by saying, welcome to the group that nobody wants to belong to, but everyone is glad is here. It's a safe place for us, a place where we know we are heard. We laugh together as we find the ridiculous in our stories, and we cry together as we experience letdown by those around us and in our treatments. We become very close, this group of strangers with nothing really in common other than we are struggling with a terminal diagnosis. And we grieve together as we lose members. It's an incredibly important group to belong to, a very difficult group to belong to, but being heard outweighs the sorrow of loss. Tom Peters, a leadership researcher and writer, quotes Harvard Med School Dr. Jerome Groopman from his book, How Doctors Think. While Groopman acknowledges that doctors respect that patients are the number one source of evidence of patients' problems, he also points to research that has shown that, on average, doctors listen to patients for 18 seconds before interrupting. Tom Peters also found this applies to managers in a range of businesses as well. So I'll extrapolate from that quote that the most important thing for a patient in an interaction with their doctor or any of their medical oncology team is to be listened to. Once we feel heard, we can start to trust. We all want to trust that our doctors, all the people who oversee our care, have our best interest at heart. That extends to trusting that my healthcare team members are listening to each other. They are communicating with each other what they have heard from me, what they've noted from seeing me, my test results, as they review my treatment plan. One of the perks, it seems, of having metastatic cancer is that when I moved to Kelowna just a couple years ago, I was assigned a new GP within a month. As I was getting to know him, I asked him about palliative care supports and facilities in Kelowna. He replied by saying that we don't need to be concerned with that just yet. He had listened to me, but he couldn't travel down that path with me. While I don't want to present that I know how to or always am emotionally strong enough to get through these difficult conversations gracefully, I'm far from that. But I don't have a choice other than to face my illness and impending death. And it would make the process so much easier if those in healthcare could guide me in knowing what I might expect. I respect and like this doctor very much. He keeps on top of my test results, has called me in to see me when there was a result he was uncertain about, and yet he still encourages me just to think positively, not to think about my end. Believe me, I don't want to focus on my end, but I do try to live the two roads. I'm hoping for the best by living each day, being active, sleeping and eating well, following my new passion of contributing to the body of knowledge in cancer care. And I want to be prepared for the time when the worst does arrive, the decisions that will need to be made. I want to have had time to give them careful thought, and my GP is one of the people that I need to lean on to give me that information. The process of learning about and finally understanding what words like metastatic and palliative mean in a clinical sense, and not in the common parlance of our society at large, has impelled me to take on a research project. I have been fortunate to be put in contact with Dr. Barb Pasalt. She holds a principal research chair in palliative and end-of-life care at UBCO. And she was intrigued by the notion of living in the upstream phase of an illness requiring palliative care, a state which she called liminal. When she used that word, I knew I had found someone who understood. So last May, myself and a friend and colleague started a year-long study of 10 metastatic cancer patients. And we're looking to answer the question, what are the experiences of persons living with advanced cancer in an existential state? Through this research, I hope to give voice to what people with metastatic cancer think and feel. So many of us are now living longer and healthier, and we need to find ways to communicate about the end of life as we live with metastatic cancer. Living while dying is not really a new concept. After all, we're all going to die sometimes. It's just so in your face with a terminal diagnosis. My life passion on how we communicate has been a guiding and motivating force in how I've dealt with my diagnosis on a personal level, trying to figure out for myself how to live fully with death looming, especially in the days when I didn't know how close death might be. And it's been very lonely, even though I have a husband who's emotionally strong. As I started searching for answers, encountering so many people with terminal metastatic cancer diagnoses, and those like you working to make these illnesses more manageable, I have been struck again and again by how difficult the communication piece is. My hope is that the work like what is taking place here today, in many places in healthcare system, and research, including mine, will provide some understanding to those who do not and who cannot understand what it feels like to live with death looming, and to provide some insight, if not reassurance, to those newly diagnosed. So fortunately, I'm out of time completely, and so I can't get into my rant about the impact that technology has had on our communication skills. But we really do need to learn to communicate clearly, compassionately, and fully about living and dying, especially when we are, very thankfully, living with illnesses like metastatic cancer so much longer. Thank you for listening to my story, and thank you for all the work that you are doing.
Thank you, Colleen. Every voice matters, and it is only by listening compassionately, attentively, and unequivocally that we can orchestrate a future where the voice of patient perspectives reverberates far and wide. I would like to now invite Professor Melba de Souza and Professor Florian Fair to deliver the keynote and call to action the World CAFÉ Summit today.
First of all, welcome. Welcome, welcome. This has been like planning a wedding, yes? And it's happening today. It is. Before I jump into the title of our keynote address, I would like to say it has been an amazing journey working with Dr. Melba de Souza, who is the main lead of this entire project, but as well keeps saying that every one of you were the leaders. So I'm confused, but to me, it's just a wonderful community event, and I am just thrilled. And I didn't sleep last night very much because I just couldn't wait for this morning to be with you. I'd like to also let you know that we have a wide variety of research assistants here that I'd love to have stand up and wave and say your names quickly so everyone knows all the background wedding planners here. So please. Melba's son, who's a wonderful support. Thank you.
Hello again, everybody. I'm Ashwin.
Isn't this awesome? What an amazing team here. And I'm Dr. Florian Fair. I've been working here for about 20 years. Graduated here from Caribou College in 1992. Westside Secondary person over there for high school, if anybody's from Kamloops. And and you're Melba.
Yes.
And I'm a huge fan of this wonderful woman. We are working together because we have some common interests. And before we go into too much of the agenda, I know we only have 10 minutes, so I got to talk really fast because I was told 0.5 seconds per, whatever that meant. But we'd like to share with you this project. This project has been going on for quite a while, and you will notice in the back we have it being videotaped, and we have Rogers cable here. Okay, right? Gotta be careful. And we have Leon here as well, who's videotaping all of this. We have already put together a 3-part filmography based on some of the research work that we're doing, and I'm saying some because it's going to keep on going. You may have noticed this is the first annual event. It's a thing now. We put it up there, right? Yeah. And we hope to keep continuing this momentum on. And we have some other work to do as well after this. So you will see throughout the day, as you already have received your full agenda, that we will be gathering after lunch today and moving forward with some potential projects to keep this going. Because we have to take advantage of this rich, beautiful audience, yes. Participants. The main focus of the project that we worked on, which most of you know already about because some of you have been taking part of it as participants, stakeholders, we've all been invested interest in it, is really regarding breast cancer. As we know, it is the leading cause of cancer for women in British Columbia. 1 in 8 women, unfortunately, in the region will experience breast cancer in their lifetime. That's pretty scary, right? And as well, we also know that there's all kinds of elements. It's not just the diagnosis itself, it is the emotional aspect, the physical, the spiritual, the carry through with our caregivers. I myself, through a lens of a child, I experienced cancer. through my mom passing on with cancer. And so we know that it's big, and we know that it is bigger than just one person, but it also is one person going into a very lonely journey potentially. And it takes a family, it takes caregivers, support systems to really work and be and listen to that person who's going through cancer. And I heard the word communication twice with our first two speakers. The need for communication is huge, and that was a big piece of why we were doing this research. How can we look at these gaps? How can we work so that there's a smoother feeling experience of dealing with cancer, living with cancer, and also carrying on so you have the highest quality of life? So we definitely wanted to look at the structured support systems and look at the experiences of the post-remission challenge, as well as looking at, does survivorship mean? And what do we need to do to make the quality of life better? And we looked at various elements, the financial aspects, the overall understanding of survivorship, and we also recognized there's some scary stats out there. We recognized that, yes, last year, 2023 stats came out, and people are passing on. So that is looming in the back of people's minds, families, people being newly diagnosed. And there's a 5-year cancer survival rate in general. Now, this is very general about all cancers, but one of the things we did learn is lung cancer is still number one, but we are seeing some interesting stats where people are living longer. And we're noticing there's a connection between supports, survivorship, communication. It prolongs life, and you have a higher quality of life. And it helps the family members, and it helps the caregivers. It's a huge domino effect, ripple effect. So we definitely want to look what we have for strengths in our society, in our communities, especially our rural communities, look at access, look at what is there, and what can we do with what we have there, because we have well-meaning folks out there that are putting together amazing services, but not talking together all the time. How can we make that better? And we're listening to our patients, our clients that are diagnosed with cancer, and telling us. They are the voice that we need to listen to. We did find in the literature and this a model that absolutely still fits with today of what our patients are entering into when they're first diagnosed with cancer. And we've noticed that 55 to 75% of those clients need ongoing services, even after having interventions. And that's super important. They're requiring it. So we have a model that's from 2008 that we can still see being used today. That hasn't changed. People are still saying we need supports. And definitely the biggest piece would be the psychosocial part, which is the main aim of our research, and pulling you all in together with that. And where it will go, who knows? Melba's got some ideas, so do I. And we know today we're going to hear a lot more. So we're really, really excited, and thanking you. And I'm going to pass this on to Melba because she will sort of finish up our little presentation here too.
Thank you very much, Florian, and thank you everyone for being here today. And along this day, I think we are going to hear a lot about initiatives in cancer, advancements in cancer, and where the way ahead is with British Columbia and the cancer plan for the policies that Health Minister Adrian Dix has put together, and looking at different organizations. But for us at this local context, I just need a time where we commemorate many of the works that the people who have had cancer have shared on. Like today, Hayley Coleman spoke about her love and passion of being and connecting with the people. Colleen Foran spoke about her love and passion being from her lived experience. Every one of you who have come here today, you have a stake today in cancer care in different ways. And this is what we are looking through our research that has been at Thompson River University through our school and working with different academicians, clinicians, partners, is to grow this transdisciplinary research and also to look at different aspects of how we can collaborate this partnership. So through the continuum in our research, we are looking at different ways and strategies and recommendations from cancer prevention with immigrants and refugees, and with marginalized population, 2S LGBTQIA+, and rural and remote areas, people who are aging, people from different races and walks in society, and how they go through with diagnosis. And some of them, Colleen mentioned today, what happens when you are informed that you have a cancer. And then going on to palliative and end of care, where we have a lot of work to do with when we look at psychosocial, spiritual, at mental health, look at emotional health, look at different areas that affect a person after treatment, during treatment, on their ongoing recurrence, metastasis. And that's our research that is looking at this. Some of our studies have focused on different intersectionality factors that predicts if a person can do well and prognose well with their treatments, and what helps the support in community, in the healthcare, with their family, with social networking, with having community integrative networks, with having this financial networks, with having legal networks that helps you to progress in your life. And most of the emphasis that we can talk from our study comes about with having the access and the use of these healthcare resources for people who are marginalized and for other people's general populations and different groups of people who are accessing to have better access and knowledge of this. Another one is having a tailored and very individualized approach to support them in survivorship, in recurrence, and getting supports from complementary, alternative, other therapies, looking at data leverage and how we can use the data that is connected here, looking at screening, early screening, survivorship time, and also looking at care plans and tailored care plans to an individual needs-based, be it cultural, being an indigenous person or non-indigenous person, and having that flexibility of what they need at that time with their cancer care, addressing equity and diversity in some of our groups here, and having different community engagement models. So one of the things is looking in our research is about looking at data analysis for risk prediction, looking at an environmental scan of what predicts them, and also having a personalized approach in their treatment. I'm just going to quickly go through. These are our top areas in research in cancer care, interdisciplinary collaboration, the people who work with that, and leveraging our data and technology that we are working with. And these are a few of our resources, and I would like to say thank you at this point for coming and being with us in this time.
Today, you're going to meet a ton of folks. Please mingle, mix, ask questions. And in the next room, you will see some of our posters that we put up to celebrate our fantastic presenters that came today. Hopefully they don't blush too much, but we have some pictures up there and some little backstories.
So we want to thank our funders for today. Thompson River University is our main to here at our academic, supports the infrastructure, the support, the faculty, and protects our time to do the research, to work with people. CHR, Canadian Institute of Health Research, is actually sponsoring this planning and dissemination, and they hope to get out of the way forward of what are our research recommendations in terms of looking at the priorities in our own local area and in British Columbia, and contributions has key performance, what's happening all over the world and in different provinces in terms of cancer and what are advancements in psychosocial oncology. Breast Cancer Society from Natalie Hamilton and from Kimberly Crenshaw, and Thompson University School of Nursing from our dean and from our leadership supporting this event today. And I also want to thank the partners who made us to see this day. We have a community advisory board where we meet once in 6 months. Interior Health, we have Michelle Smith, Michelle Smith, Paula Morinson, Danny Whittle, who's been with us. BC Cancer, we have Ruby Gidda from Abbotsford, and we have Andrea Knox, who is going to be with us today, and Jennifer Edgecombe, sitting right there. Might have seen her when she was sitting there. Inspire Health Supportive Care, we were supposed to have Dr. Hannah Nette and Lovina Shira, who would be with us. From the University of British Columbia, we will have today Dr. Ian Mitchell.
He's working right now, but he's on his way.
Okay. University of Saskatchewan, we have Professor Louise Racine, and from Kamloops Cancer Society, we have so many supporters. We have Anne Beruta, Leslie Brochu, who is online, Janice McDonald, Deb, and then we have Kamloops Breast Cancer Support Group. We again have Anne, Beruta, and then who else do we have from that? Grace Brossier, Cheryl Diddles, and so many support groups we have. Canadian Mental Health Association, maybe Alfred Achoba will come by today. We have from Valid Dreams Foundation, Sally Martin, who is supporting us. Spirit Warriors, Kamloops, BC, we have again Anne, Beruta.
What don't you do?
Ask Wellness Society, we have Alicia Hamilton, Bob Hughes, Taylor Pretty. I don't know if
She's
she's
coming in.
Okay.
She's a social worker working this morning, but she will be here.
CanSol. We have Michael Cohn from CAN and Mind Solutions. Kamloops Immigrant Services, we have Jenny Tran, and we have the CEO. I can't really remember her name right now. I think it's Frank Lamberton. She's with us. And then we are also launching our Cancer Care Innovation Synergy Partnership. You have, our students have introduced themselves to you. So we are also working with Catherine Dixon from Northwest Territories on our cancer lab. And we are working with professional navigation with Ruby Kitta and Karma Lali. She's one of our students online. Karma Lali, are you still there? Can you unmute and so, yes. Can you introduce yourself?
I'm Carmel Lally. I work with Melba as an undergraduate research assistant, and now I'm just volunteering for the event here today.
And for the decision support applications, we have Dr. Saika Alim, who's working with us, Gopi and Aditya. For interdisciplinary psychosocial oncology, we have Michelle Smith and Ash. For simulation research, we have Dr. Hannah Nete and Alex Ruskin. So these are some of our labs that we are working together in our research to have innovation, synergy, and partnership. And today we're going to open the summit now for the speakers.
Thank you, professors, for engaging us in this meaningful conversation and being part of a collaborative spirit that defines this summit. In my journey as a student researcher, I've had the privilege of witnessing the impact that arises when individuals come together with a shared vision for positive change. We will now have 15-minute speaker presentations, and if there's time, some questions. Now I'd like to invite Professor Silviana Mima, Deputy Chief Medical Health Officer from the Community Health and Services Center of Kelowna, who's at the forefront of this movement.
Good morning, everybody. I'm Silvina Mema. I'm the Deputy Chief Medical Health Officer with Interior Health. And thank you for inviting me to talk today. And what a way to start the day today. Very emotional, and many lives are touched by cancer. And I just want to acknowledge that. It's an emotional journey. It's not just about the science, it's about the emotions that we feel when these topics are discussed. So first of all, our land acknowledgement, Interior Health covers a wide region, and it's the unceded territories of the Dakel Dane, the Tenaha, Nlakapmak, Shewepmik, Statlik, Silks, and Chilcotin nations. Next, please. So my focus of work is about prevention of disease and injury, and cancer being one of the chronic diseases that we work to prevent. So here in this chart is the top causes of death in BC. And as you can see, malignant cancers are at the top of the percentage of deaths, right? Like the percentage of why people die in the province. Now, the yellow that you see here is the current toxic drug crisis, the public health emergency that was declared in 2006. So it follows close behind, but that doesn't change the top cause of death is malignant cancer. Next. So as it was mentioned before, Melba mentioned, there is the 10-year action plan for cancer in the province that was launched last year. And there is 4 strategies that are mentioned in that action plan. So the first one is to prevent cancer and find it earlier. The second is ensure timely access to treatment. The third one is optimize care through collaboration and partnerships. And the fourth is revitalize the cancer system through essential enablers. And the 10-year goals are to reduce the incidence of cancer, improve survival, and ensure a strong system delivering modern, evidence-based, and province-wide cancer care. Next. So the first strategy is the one that public health, my group of medical health officers and the population health team in Interior Health is concerned with. Next, please. So what do we talk about when we talk about cancer prevention and the population health approach? Next. The population health approach is an approach to disease prevention that uses 8 pillars. So there is 8 pillars in which the population health approach is based on. So the first one is to focus on the health of the population. As opposed to focusing on an individual person, we focus on the health of large groups of people. The second is addressing the determinants of health and their interactions. So we understand that disease happens for a reason. It's not just a chance or an accident, although sometimes some diseases cannot be prevented, unfortunately, and that includes some types of cancers. But there is a lot of underlying factors that can play a role in whether a person gets sick or not, or how they cope with the disease once they have it. So that has to do with the determinants of health. We base decisions on evidence. We are very diligent in terms of separating values and opinions from what is really the evidence saying. And we advocate for increasing upstream investment. So things like education or health promotion campaigns, early childhood development, in impacting the social determinants and the factors that have a role resulting in disease. We also understand that one intervention alone is never the silver bullet. There is usually, most of the times, you need to apply a number of interventions. So we tackle issues as for a multi-pronged approach. And we need to collaborate across sectors. Public health cannot exist as a silo. Public health, by definition, needs collaboration. It needs to be picking the brain of everybody that is involved in certain particular issue. And cancer is a great example, because although we want to prevent cancer upstream, we also need to understand the patient's voice, the physician's perspective, and the number of other things. We need to employ mechanisms for public involvement. It's very important to understand the user. The end goal is to change outcomes for the people, and we need to understand why people behave in certain ways, or why they believe in certain things that perhaps are putting them at risk down the road. And finally, demonstrate accountability for health outcomes. There is a need to look at data and to understand how the investment produced or did not produce results, and be humble, really, and be ready to change our course if we cannot really demonstrate outcomes from our work. So understanding population risk factors. So for individuals, individual risk factors include things like in the person's age, their sex, their level of education, their behavioral, how they behave, what they do, what they eat, do they exercise, do they use tobacco, and then intermediate risk factors. So things that are a precursor to the disease, like, for example, blood lipids or diabetes or high blood pressure, overweight. So those are individual factors. At the population level, those factors translate into social and economic conditions. Is a community, what are the opportunities in that community for employment? What is the family composition? What is the environment in that particular community? What's the climate? Is there air pollution? Is there a healthy environment where people can exercise, can walk to work? Or is it car dependent? What's the culture? What's the values, the norms? Is it cool to smoke? Is it cool to do something that is unhealthy or can put people at risk? And why is that? And then the community as a whole. What is the neighborhood look like? What is the neighborhood like? Do people feel safe in that neighborhood? Can they access the products and the things that they need to thrive? Next. So here is an interesting concept that is population attributable risk. And those of you familiar with epidemiology are probably familiar with this term. What population attributable risk does is it pinpoints what is the percentage or the proportion of certain disease, in this case cancer, that can be attributed to certain risk factor. For example, we know that we cannot prevent all cancers. Even if we had the best possible healthcare system with the best possible prevention systems, we are going to have individuals that have cancer. And that is because of their genetics and because their biology, and that cannot be changed in some instances. Now, we know that if on top of that we add certain risk factors, like for example, tobacco smoking, we are going to increase the proportion or the number of people that have lung cancer. So what population attributable risk does is it tells us what was the background level of disease that we were going to get. And then on top of that, what is the added number or proportion of cancers that we are getting because of that particular risk factor. So here we have a population attributable risk in BC. We took this from a national study, population attributable risk for different risk factors, and we applied it to the BC numbers to see how many cancers are there attributable to specific risk factors. So as you can see here on top, tobacco smoking is at the top. So the number of new cancer diagnoses that could be prevented if nobody smoked, if there was zero tobacco, was 4,000 cases. And that is for 2015, right? Like we applied these to the cases in 2015. And the next one is low physical activity, 1,300 cases of cancer, low fruit intake, 900 cancer cases, and then it keeps going. Excess weight, HPV infection, UV exposure, sedentary behavior, alcohol, other infections, and you can read the next. You can see the rest ones. So what this tells us is that 4 in 10 cases of cancers are caused by modifiable risk factors. So this is an important number. It's almost half of the cancers are, they have a cause that could be, at least in theory, be modified. So there is a very nice document that came up recently. In fact, it's not yet posted online, and it's by the BC Cancer. And it talks about the 8 top exposures that cancer can be attributed to. And it talks about the different levels at which we can intervene to prevent those. So things like at the individual level, what you can do for smoking, you can give people a nicotine patch, nicotine replacement therapies. At the interpersonal level, what are those peer norms, the peer pressure, or at the organizational level, what are the policies of the organizations, the universities, the health authorities that allow to move forward with an agenda that prevents exposure to risk factors. At the community level, the norms at the community level in terms of, for example, smoking or any other physical activity. Are there, places where people can go and find recreation, things like that. And then lastly, the public policy level, which is really the legislative framework that we have. And for tobacco is very clear that smoking has, how in the past 20 years that has progressed towards denormalizing and allowing for smoking to become less and less prevalent. Next. Keep going. So we talked about the population approach, and this is about the clinical approaches to cancer prevention. So in BC, we have something called the Lifetime Prevention Schedule. And what the Lifetime Prevention Schedule is a guide that guides clinical practice and with interventions that are cost effective. So if it's in the Lifetime Prevention Schedule, it means that it needs to be applied by clinicians because it is known to reduce costs in the health system. So things in the Lifetime Prevention Schedule include screening for certain cancers, behavioral counseling for smoking cessation, interventions to reduce alcohol use, obesity management. Lifetime Prevention Schedule also includes immunizations that prevent cancer like HPV, and screening for risk factors like obesity. Obesity is a risk factor for cancer, and that is in the Lifetime Prevention Schedule. Next. Keep going. I'm going to go quickly through these graphs are based on data that comes from population health surveys. So in 2021, there were population health surveys that asked people, what do you smoke? What do you eat? Etc. So I just want to draw to your attention to the bottom here, and this is the BC average. For example, percentage of people that smoked or vaped daily or occasionally in BC was 13. In the interior region was generally higher. Here is IH, 14%. And here is the different areas of IH, Thompson Caribou, where we are now having the highest. And here is the same, so provincial average for binge drinking alcohol. And as you can see, interior health is also generally higher than the provincial average. Next. This one is about fruits and vegetable consumption, which we know is a factor that prevents cancer. And here we have BC 22.3 is the average, and generally higher or at, no, this one we are better for fruit and vegetable consumption in the interior. Kootenay boundary being the one with the highest fruit and veggie consumption. And here is physical activity. And what percentage of the population engage in moderately or vigorously physical activity. Here is BC, in the interior region, a little bit higher, which is good. Next. And I'm just going to show you one slide on cancer screening. There is a lot to talk about cancer screening, but I'm just going to show you breast cancer screening. This is breast cancer screening in BC. It's the gray lines, and the blue ones is IH. And this is only up until 2020. I couldn't get a lot of very updated data. And generally, you see interior health is slightly below the provincial average, but the target is 70% participation. And we are here hovering around 45%, 44%. So there is a lot of work to do in terms of cancer screening in BC and particularly in the interior region. And this is about HPV vaccination. So HPV vaccination for girls and for boys. And this is the pandemic year. And you can see how it dropped. During the pandemic year, HPV vaccination significantly declined. And it's one of the priorities in the minister's, the provincial strategy. And lastly, the last factor I'm really passionate about is radon. And radon is a radioactive gas, and it's quite prevalent in the interior region. This map shows this is the interior region. The red areas are areas where over 30% of homes have unhealthy levels of radon. And in this graph, you can see by communities. So for example, in Castlegar, up to 50% of homes have levels of radon that exceed the Canadian guideline, which is 200 becquerel per cubic meter. So radon is, in my opinion, one of those neglected risk factors that people don't talk about, don't know about, and it's because it's not a provincial issue. It's certainly more of an issue in the interior region, and particularly in the Kootenays, although everywhere in IH. It's not, and I'm taking it personally to create awareness and to talk to different organizations across the province to increase awareness about radon. And we are doing a pilot at schools where we have tested most of the schools for radon. Next. And this is the last slide I have, projection of new cancer diagnosis and in BC. And I don't have to, you can see the trend here of the orange lines increasing. We are going to see more cases of cancer in BC. We are also seeing an increase in the population. So we really need to focus on prevention as much as we can, so that we can really, target with treatment and interventions those cancers that we couldn't prevent. Next. So this is the medical health officer team. This is our chief medical health officer, Dr. Martin Lavoie, and the rest of the medical health officers. We have geographic assignments, and we are always happy to connect with partners and talk. And we have 3 new medical health officers that have been added to the team in the past week, and we have one of them here, Andy, who is a new medical health officer that joined the team recently. Okay, thank you for that. Thank you.
Thank you, Professor, for sharing how public health plays a key role in this narrative. I'd like to now invite Mr. Gunashila Shetty, a registered nurse from Ireland, to share insights into survivorship that must extend beyond the clinical setting, encompassing considerations for social determinants of health. He's an online speaker.
Good morning to everyone. I'm Kunashila Shetty, and thanks for being part of this World Summit. And just to give you my background, as it was introduced, I'm working in Ireland for nearly 20 years, and I'm just going to share my experience, my journey of survivorship with you all. So, my journey just started 2 decades ago. Sorry, just the Ireland, I chose the Ireland as the new home nearly 2 decades ago. Nearly 20 years I'm living in this country. I should say I will more or less raised with the Irish culture and Irish immigration, but as it is much prevalent in most of the first generational immigrants, my always be much attached with my home country, India, and usually is to travel frequently to India to meet with my family, friends, and that was the same thing I was doing in 2018 on my holiday, but this holiday turned into a nightmare. I never expected that one day I'll be called as a cancer patient, but without, a relatively healthy lifestyle I had, and I was much having a good time in India, but it just on one fine morning, with the slightest, like as I was telling earlier, Ireland, I've chosen Ireland as my new home for nearly for the 2 decades, and but still much associated with my hometown is in my home country, India, though I culturally integrated with the Irish culture, but still much associated with the Indian origin. But in 2018, my holiday turned to be a nightmare where I was diagnosed with the cancer. I came back to Ireland for the continuing my treatment, and then I should say my new normal or the new beginning is started. But when I say new normal or new beginning, I think having a diagnosis with the cancer, so even though I work in health sector, I think it will have a more impact for any person, whichever the advancement of the treatment we are having. But I think still we are much associated with that term big C. It gives a fear to everyone. So I'm not the exception for that. And that was a big shock. And I think it is not that I never thought why me, rather I questioned why now. So that was the first thing, and the next one I was thinking, how long? So these are the two basic things which came up to my mind when my initial diagnosis, but luckily all the treatment that is continued here, then the new normal, when I say, I think you will have a lot of, as a part of your treatment, you will have a physical, mental, psychological, financial, all these issues will come, but you have to say through that. And then when you started to move forward, you have to accept if we were not able to live like how we used to live pre-cancer stage or pre-diagnosis, but then you have to accept it as your new beginning, and you have to move on with your next life of the cancer survivorship. Can you go to, yeah, just to give you a perspective of the Irish cancer survivorship data, I think it's the latest NCRI report, it says around 4.2% of the Irish population are cancer survivors. It's obviously, as you all agree with me, the advancement of the treatment, the better surveillance, all this has given the higher rate of the survivorship, but still, as it was rightly said before, the cancer still is a major cause for the death, one of the major cause for the death. So, uh, so as a national cancer strategy of ours is defined survivorship begins with the diagnosis and continues until the end of the life. But for me, when I turned to cancer survivorship, it was, though it was difficult to accept as a cancer patient, but I say you have some sort of the safety net when you are under care of the treating team. But the day when you have to move away from that, when you are almost in the verge of discharging from the regular treatment, and you say you're becoming cancer survivor, though the definition says it is right from the day of the beginning diagnosis of the cancer, you are called a cancer survivor. But in the reality, I feel once you're almost finishing your treatment cycle, then you are going away as you are going to be discharged. You will be much higher stress. Because you will be losing out your safety net, and you are almost like you are going to be living your own, and there is so much anxiety associated with that. I think that is one of the biggest challenge what you have being a cancer survivor. So for the being for that aspect, I think what we needed is a holistic a recovery of the survivorship care, which needs to be focused on for any person who is suffering with cancer. Can we go to the next slide, please? Cancer survivorship support, what we got in because there are a lot of survival programs and survival support is going on, but what I focus is only on what are the aspects I have inculcated, what are the aspects I have used while in my journey of the cancer survivorship. The one of that is the aspect, if I take the financial or going back to work, because that is for anyone. I know the money is not the everything, but you need the money to survive, to have a decent life. So that is one very essential. And when you have a disease like cancer, and you have a lot of trouble and going back to the work, and you may be psychologically you are much affected, you are physically you are affected. So going back to the work is maybe really challenged. So that is one thing which may have to, everyone may have to be much focus needs to be, maybe has to be provided. But for me, when I'm in this journey, I think there was a very good support I received from my employer or from my healthcare setting. Especially like when I decided, when I was planning to go back, there was always, I had a regular contact from my employer, and there was a plan in place how to go back, because certainly I was not in a position to go back to the duty what I was doing previously, or the way I was working previously. There was always need for the restructuring of my work. So there was all negotiation was with my management, and they were much proactive in that. And then we have to work with that, work around with that, what skill set I have, and we have to reassess that, or maybe some of the skill set I have to reskill myself to suit the job which I am going to do as I come back. So maybe I started with initially with maybe just with a half time, then slowly I started building up. So I think this is one very crucial one where every survivor needs to be provided with enough information, because you have plenty of the things are going on with you. You may not have any clue how to go about, how to go back to work, how to start your work. Are you able to do your new your goal what you were doing previously, or what changes you need to do, and how that can be facilitated. So for that, you need to have a constant contact with your employer, and employer support is very essential in this aspect. I think I'm lucky enough to have a very good system in place, and there is a great support has been provided, and I think every cancer survivor need to have that support, and healthcare system or the government policies need to be directed towards on that aspect. Can we go to the next slide, please? Yeah, but having said that, everything cannot be spoon-fed. the patients, every patient's, though you are whichever the stage of your journey, once you are there, almost ready to come back, every patient needs to play an important role in their own recovery, both mentally and physically. It is challenging. It is not as easy what we are saying. It is definitely challenging, but the one has to take one has to take a call, how to go about, how to take a individual or the personal responsibilities. Uh, the meantime, health services or the health sector has to support system need to be in place to support the survivors, support the cancer patients, and empower them with the different requirement what they need, what the changes they need needs to be provided. Or cancer survivors who are living with and beyond the cancer should be seen as a continuum of cancer care. It cannot be, or it cannot be one stop, or it cannot be one shop go. It has to be continual. It has to be taken with the holistic approach. Because one cannot be just looking to their one physical health, mental health. It has to be for all the areas, physical, mental, spiritual, and intellectual, all aspects when it is covered. And so then it might be much better approach with the support from the service provider. Can you go in the next slide, please? And as for the psychological aspect, it was definitely one of the toughest challenge I ever faced during this, because, so I was under the best team, best multidisciplinary team for my treatment. There was no problem with that, but still, when you're living maybe thousands of kilometers away from thousands of miles away from your home country and away from your family, away from your good safety network, and when you are just living with a different country and with the fear of cancer, and maybe to the extent that it is not exaggeration to say fear of dying in other unknown country, and that was one of the biggest fear one will have, and definitely psychologically it was much challenging. So at that stage, I think there was a good support system which was provided to the oncopsychology department. And just to give an idea how it works here in Ireland, it was like previously there was a different cancer support systems they used to work, and they used to provide the psychological support. But from the recent national strategy of 2017 to 2027, yeah, that is the national cancer strategy, they emphasized on collaboration of all these support centers together. So they formed as a this was the alliance, that is the collaboration of all the cancer support centers together. So through that, the cancer, whoever is the cancer survivor, if you have any difficulties in the psychosocial aspect, they can, so any time they can refer themselves, or they can refer from the hospital, or they can self-refer themselves to these centers, and these centers are brilliant in providing confidential psychosocial support. And as well for the workplace, there is an employee assistance program. Sometimes when you are working, and I'm a pediatric as well as a mental health nurse, when we mental health nurses, sometimes we take it granted, oh, we know everything, that is just a talk therapy, it may not be much useful, that's what we do every day and day-to-day life, so that's of no good. But maybe I was in the same mindset, but in fact, I have to tell you this thing is my wife has just referred me to the employee assistance program. One fine morning, I get a call from the employee assistance program psychologist, and he says, Gunshil, this is me, and are you interested to speak to me? And then I said, okay, yeah, go on. Then when I went to him, when I opened up myself to him, I think that was a great help ever I got. That was the ultimate help, I think, which I myself never would have got it once I got referred to that, and that was a great support which I got in that state. So that is another brilliant program what we are having. That was definitely much support which was given to that. And also in the last year, the 2022 National Cancer Control Program and Survivorship Program, they said there is a psycho-oncology department needs to be in each area as well as in the community, and also they recommended for the nursing specialists, that is the psycho-oncology, cancer nursing specialists in each team. I think that is much helpful for the survivors. Can we go for next? And this is another model which we are actually looking in Ireland is recent. This is again as a part of the new strategy, that is the National Cancer Strategy. They have come up with at least this is the new cancer survivorship care model which we are practicing currently. It is started rolling out. Then they broad principles they're taken into like assess, link in, link out, onward, inform, empower, support, and services. Because as you know, there are different types of the cancer survivorship programs existing, which may be physician-led, nurse-led, community-led, and there are different times, different places. But by studying all that, I think our health system has come out with this is one of the service providing for the model of the cancer survivorship care, which were given this based on this risk stratification of the patient will be done, and the survivorship pathway, with each pathway, all these principles will be applied and assess the patient, and then the continuous support will be provided to the patients. I think this is one, and also like the cancer survivors passport. I think that's one of the brilliant item what they're having. Which was usual previously. I remember when I'm doing one as my project, I did it one was on ID patients. So now same thing has been implemented on the cancer patients. So those passports will give every detail about the patients and his appointments, what is it, where he is going next, and what are the resources available, where he is referred, and when his appointment is coming. Everything, holistic, everything is present to him. He will have access to every data what he is going through the further future in his care. That is one of the good things what we are having at the moment in this world. So that's the current model what we are looking at the Irish healthcare system. Can we go next slide, please? Apart from that, there are other national cancer control survivorship programs. Survivorship programs are run, like one is Thriving and Surviving. I think everybody will be definitely familiar with this. Is the Stanford University adopted program, which runs for the 6 weeks. It is for the 2.5 hours, and this is again self-patient, management, evidence self-management for the survivorship program, and also another is the LACES. It's the Life and the Cancer Enhancing Survivorship Workshop, and similar. There are many others. I'm just touching only which I am exposed during my survivorship journey. There are many other programs are available, but these are some of the programs which currently runs here. Next slide, please. And this is the one which I'm very closely associated. This is one that recently launched. It's a new initiative from our service executive or the health sector from Ireland. For the health sector workers, that is the HSC workers, they introduced this program for survivors by survivors. So this is the new development which is provided by the Irish health workers, who are the employees of the HSCs, who are diagnosed with the cancers, providing the survivor peer support to the people who are diagnosed with this cancer in this service. And this is basically just the befriending or the listening service. We are not providing any clinical guidance or the clinical support. It's kind of a navigating service and empowering the patients, their stage of any stage of trajectory of their cancer survivorship. What are the resources available? What are the resources available in the within the service, or if it is outside the services, or any stage, if they wanted to have the psychological support or the emotional support, more or less the empathetical approach what we use in this one. This is a new initiative we started, and a part of it, it is purely runs as a voluntary program, and it's much of peer support to the co-workers which is provided. It's just launched a couple of weeks back, and we are in the very initial stage of the evaluation of this program. Thank you.
Thank you, Mr. Shetty. Truly, survivorship plays a crucial role in shaping the landscape of cancer care, advocating for research, and fostering a culture of support. Knowledge translation lies at the core of our endeavors, bridging the gap between theory and practice. Now I'd like to invite Andrea Knox to share research findings into tangible benefits for patients and communities.
So glad to be here today, everyone. My name is Andrea Knox, and I'm the Director for Nursing and Allied Health Research and Knowledge Translation here at BC Cancer, and it's my distinct pleasure to be with you all today to share the story of our novel department and some of the exciting work that we're doing. But before I begin, I do just want to take a moment and acknowledge with respect that I'm speaking to you today from the unceded ancestral and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations of the Coast Salish peoples. But I do actually live, work, and play on the traditional territories of the Syilx Okanagan peoples, which is what is colonially known as Kelowna, BC. So today I'm going to provide you with just a quick overview of our department and some of the work that we've started over the last 3 years, and highlight our ongoing efforts to advance innovation and excellence in interprofessional research and knowledge mobilization by creating a center of excellence for nursing and allied health research. And so our department consists of nurses and allied health providers who are uniquely positioned within our organization. And these roles seamlessly bridge operations, clinical practice, and research, and get to apply their research and analytical skills directly within our health system to advance pressing priorities with evidence. So to set us off on the right path, we actually collaborated right out of the gate with individuals and teams across BC Cancer and the BC research landscape to help pinpoint 6 strategic priority areas of focus for the first 5 years of our department. And these priorities include focusing on strengthening and leading research in nursing and allied health at BC Cancer, working to enhance knowledge mobilization to maximize the impact of that research in practice, policy, and healthcare decision-making, establishing an integrated academic training pipeline to cultivate the future generation of research talent, developing the necessary infrastructure and resources for nurses and allied health providers to lead and engage in research and knowledge mobilization, working to foster internal and external partnerships to encourage collaboration across that historical divide that we've seen between academia, practice, and operations in healthcare. And finally, of course, we can't do any of this without money, so part of our work is formulating a funding strategy to support all the fantastic nursing and allied health research and knowledge mobilization projects that we hope to see. And so once our priorities were identified, work began to establish the infrastructure that we would need to facilitate research and integrate some novel roles for nurses and allied health providers to help us achieve these lofty goals. And so some select examples of our achievements in the first 3 years include establishing the first of its kind nutrition knowledge mobilization dietitian role, the first nurse practitioner clinician scientist role in BC, and just recently we launched our brand new clinical research specialist radiation therapist role. We've also established new skill development programs for staff, attracted a cadre of research trainees, and co-founded the Cancer Health Equity Collaborative, which I'll speak a little bit more about later. So with some of these foundational pieces falling into place, our focus then quickly shifted towards building out a strong program of nursing and allied health research in partnership with clinicians, health systems leaders, and policymakers, as well as patient and family partners. Currently, the focus of our research is to build health system resiliency by tackling systemic equity and workforce challenges. And right now, we are leading several projects which will serve as the foundation for a series of work in the future that aligns with the new BC 10-year Cancer Action Plan that was announced last year. And equity is definitely a trending topic right now that has emerged as a priority within cancer care. And this is because despite a publicly funded healthcare system, people with lived experience of health and social inequities face alarming disparities across the cancer continuum. And this includes being diagnosed with preventable cancers at rates that surpass the general population, dying of cancers that are often curable, being diagnosed in an advanced stage for screening detectable cancers, experiencing poor symptom management, and sometimes receiving insufficient palliative and/or end-of-life care. So as one of the first teams to step into the healthcare equity space in the context of cancer, we were presented with the unique opportunity to characterize the current state of how health equity is being taken up by the cancer system in Canada. So we started this work by hosting a series of engagement sessions with funding support from a Michael Smith Convening and Collaborating Grant, which we also refer to as our C2 project. And the focus of this project was really to explore the top priorities and concerns regarding cancer-related health equity, including how these issues are being or might be addressed at the individual and systems level. Through these sessions, we identified 5 priority areas to advance equity-oriented cancer care. And this work has actually laid the foundation for our robust program on equity research. So building on our learnings from the C2 project, we recently received funding from the Canadian Partnership Against Cancer to develop and implement a 2-phase, evidence-based equity model of team-based care. This implementation research aims to strengthen BC Cancer's organizational capacity to deliver team-based care with a strong equity focus, especially for those who are currently underserved within the cancer sector. Another example is our Canadian Cancer Society funded equity grant, which is focusing on cultivating relationships to establish a research collaboration that focuses on redressing the modifiable cancer-related disparities in the poorest postal code in Canada, the downtown east side in Vancouver. These projects have catalyzed a lot of key relationships across academia and the health system, and now our research team is tackling other issues like how mental health and substance misuse, compounded by poverty and housing insecurity, creates multiple barriers for individuals seeking or referred to cancer care. Our foundational work to advance health and healthcare equity has already sparked practical ideas, research opportunities, and new partnerships. And this has actually led to the formation of the Cancer Health Equity Collaborative, or CHEC, that I referred to closer to the start of the presentation. And CHEC is actually a team of academic and health system partners who are leading the development of new strategies to improve equity within the cancer care sector. The work of this group aims to make equity a strategic priority through collaborating with frontline community organizations, patient and family partners, and the development of organizational structures to support equity-focused care. But equity-focused research is not all we do. We are also leading some exciting work to evaluate the staff and provider experiences in team-based care, implementing electronic patient-reported outcome measures in routine nursing-led breast cancer follow-up clinics, optimizing the role of nurses in advanced care planning, investigating the factors affecting the pursuit of specialty certification in oncology nursing, and conducting a trial on intermittent fasting in cancer patients. This research is spearheaded by clinicians for clinicians, with a tremendous level of interest and engagement from all levels of the organization, right from direct care up through senior executive leadership. And alongside the department-led research, we also support research career development through our experiential training pathway. Our training pathway provides master's and PhD candidates, postdoctoral researchers, and early career scholars with a platform to cultivate their embedded research projects and programs. So in effect, positioning them to make change with their research right within the healthcare system. The research conducted by our current fellows closely aligns with health system priorities, and they're focusing on areas such as equitable access to cancer treatment, the transformative use of digital tools in the nursing workforce, and the examination of the unique needs of Punjabi Sikh patients throughout the cancer treatment journey, among many other important topics. And so as you can see, we've been able to build a strong research portfolio in our short 3 years. But to truly drive innovations at the point of care and shift our culture towards becoming a true learning health system, we need to provide our staff with the opportunity, training, and resources to participate in research and knowledge translation. And to accomplish this, our department has several hallmark programs designed specifically for our direct care clinicians. And the first one I'd like to highlight is our BC Cancer Practice-Based Research Challenge. And the Research Challenge is our annual program that offers employees with limited or no research experience the opportunity to learn basic research skills and work with a mentor on a project of their choosing. To date, the Research Challenge has provided training on the different stages of the research process to 14 teams comprised of over 100 BC Cancer staff. And many teams have gone on to share their findings at conferences, special seminar series, and publications. And the ones you see on the screen here are just a few examples of some of the teams that have gone through our program. But as impactful as research is, moving research evidence into practice is just as critical. Our Knowledge Translation Challenge program was developed in partnership with Vancouver Coastal and Providence Health to do just that, help clinicians learn how to translate and implement research findings at the point of care. To date, the KT Challenge has provided training and support to close to 40 BC Cancer staff, and 2 of the projects are shared here. They're actually from our very first cohort in 2019, and both of which are on track to complete in June of this year. So we're very excited to hear about the results of these 2 projects. Our next staff-facing program is our Research in KT Learning Collaborative, which is a bi-monthly forum where clinicians across the nursing and allied health disciplines can come together for shared learning and knowledge mobilization. And we actually open this up to anyone from any healthcare organization or institution that's interested. You're more than welcome to join these sessions. Since its inception, the Learning Collaborative has hosted over 14 sessions on a variety of research and KT-related topics, including research results, resources to support research and KT initiatives, foundational skills training, and more. And to date, over 300 staff have engaged actively in our live sessions, each of which are recorded and made available on our website for on-demand viewing. And the most recent addition to our Hallmark program catalog is our brand new Planetary Health Nursing Internship program, which has been developed to address climate-related challenges within the clinical environment, while also providing an opportunity for nurses who are interested to learn more about quality improvement and knowledge translation methodologies. In our current climate crisis, we know that the health of our planet impacts human health, and most importantly in our context, has implications on cancer incidence and outcomes. As the healthcare industry is a major contributor to greenhouse gases, we all have a responsibility to evaluate our own contributions to this crisis and take action to ensure innovative and sustainable solutions are in place to tackle these problems. So supporting nursing and allied health research and knowledge translation within a healthcare organization also requires setting up distinct structures and processes that have not been provided in the construct of historical research practices for nursing and allied health clinicians. So to accomplish this, we have set up new awards programs to fund nursing and allied health research studies. We've established new relationships with university programs and faculty to facilitate graduate training for staff. We've created novel fellowships and new job descriptions that actually allow nursing and allied health clinicians to hold research funding or even seek out paid research opportunities. All of these things were not necessarily available to our clinicians prior to the creation of our department. And lastly, and most importantly, as a team, we feel quite strongly that you can't build a center of excellence in nursing and allied health research and knowledge translation without including the voice of those for whom we are seeking to improve the system. Engaging patient and family and community partners as key collaborators in each of our research projects and the development and ongoing evaluation of our Hallmark programs helps guide us to ensure all the work that we do is oriented towards meeting the needs of our patients and their chosen families. So over the last 3 years, we've been able to create something we think is truly special, and we regularly hear from staff just how grateful they are for the direct support our team provides on a daily basis. And organizations from across Canada have even begun reaching out to ask how we do what we do and how they can replicate it. And so with that, I'd actually like to conclude with an invitation to all of you. I've basically given you a very summary overview of what our department has done in 3 years in the last 15 minutes, and there's so much more that I could possibly share. But I will say we're committed to expanding our research and knowledge translation partnerships, and we welcome any opportunity to learn and work together in order to shape and produce innovative and impactful health systems research. So please feel free to reach out to me directly by email or check out our webpage using the QR code here to explore our programs, our projects, and our resources in more detail. So thank you.
Thank you, Andrea, for guiding our shared values of compassion, integrity, and excellence.